4.5 lakh per microliter. Narrow biopsy showing proliferation mainly of megakaryocytes, an increased number of enlarged mature megakaryocytes, with one important finding is hyperlobulated nuclei. And this should not fit into the WHO criteria for CML or PMF. And if there is a presence of any gene mutation such as JAK2, CALR, or MPL, that adds to the diagnosis. And one of the minor criteria that
Dr. Princey, you are muted. Yes.
am I audible now?
Yes, now audible.
Okay. And it is because of the overproduction of the platelets, and it has tendency to both thrombosis and hemorrhage. We'll talk about why thrombosis and hemorrhage. Isolated thrombocytosis can also be the initial clinical presentation of polycythemia vera or CML. It was first described by Epstein and Gödel in 1934. Epidemiology is 1 to 2 per 100,000 patients. Younger female patients are higher in number. Younger means less than 45 years of age. Median age of diagnosis is 60 years. Very rarely found in children. And it is seen in 1/3 of the cases of CML or myeloproliferative disorders that are BCR ABL gene negative. So, in the etiology, basically, what happens is that there is a production of colony forming units, megakaryocyte colony forming units are produced. This protein is produced in higher amount, and basically what happens when megakaryocytes are being produced, they are dependent on thrombopoietin for the differentiation of megakaryocytes into platelets. So what happens in essential thrombocytosis is that these CFU meg these CFU meg colonies, they become independent of the effect of thrombopoietin, and they produce large number of platelets. There is increased sensitivity to interleukin 3. So even a small amount of protein, this cytokine gives rise to the higher differentiation of megakaryocytes into platelets. And there is decreased sensitivity of these megakaryocytes that are forming platelets to the TGF beta factor, maybe because of the resistance to TGF beta in these cells. So the features that are suggestive of autonomous cause of thrombocytosis. Autonomous means primary thrombocytosis, which is due to myeloproliferative disorder. These include unexplained vasomotor symptoms. Vasomotor symptoms can be due to microcirculation involvement, which is seen in almost 40% of the patient, or macrocirculation involvement, which is seen in almost 25% of the patients. So in microcirculation involvement, they will present as headache, lightheadedness, erythromelalgia, angina, MI, etc., blurred vision. In macrocirculation involvement, the larger veins or arteries will be involved, like splenic vein thrombosis can be there. There can be CVT. These symptoms would be present. Then there would be constitutional symptoms in the form of fatigue, weight loss, night sweats, etc. Splenomegaly is present in almost 40% of the cases of essential thrombocytopenia. Although in secondary thrombocytosis, it is very uncommon as compared to primary thrombocytosis. And in primary thrombocytosis, the unusual sites or multiple site thrombosis occurs, and it is usually seen in younger patients. So these can be hepatic vein, portal vein. These can present as cerebral sinus thrombosis, Budd-Chiari syndrome, etc. The blood smear in case of primary thrombocytosis will reveal leukemic blast or leukoerythroblastic features, while in secondary thrombocytosis, it may show the Heinz bodies or Pappenheimer bodies or an increased number of platelets. There in primary thrombocytosis, there will be an unexplained history of thrombocytosis. As we've already talked, the vasomotor symptoms would include headache, lightheadedness, syncopal attacks, chest pain, acral paresthesia, or acral pain that is called as erythromelalgia, libido reticularis, and transient visual disturbances. Asymptomatic diagnosis is seen in 45 to 50% of the cases. Vasomotor symptoms are seen in 40% of the patients. Hemorrhage is seen in almost 35% and thrombosis in 22%. In pregnancy, it can lead to various outcomes such as fetal loss, IUGR, etc. Palpable splenomegaly is seen in almost 40% of the patient in essential thrombocytosis. These are the slides for erythromelalgia. Because of the block in the peripheral or acral circulation, there is pain and there is reddish discoloration of the extremities. This is called erythromelalgia. So this slide shows the clinical presentation depending upon the mutation that we talked about. If there is a JAK-STAT mutation, there is a highest risk of thrombosis. And there is also a high risk of conversion to polycythemia vera malignancy. TLC and hemoglobin would be higher. But in case of CLR, the patient is generally younger in age, generally male, and there are lower risk of thrombosis. And MPNL mutation, there is no prognostic significance of this mutation. So the genetic mutations, like JAK2 mutation is seen in 65% of the ET patients, that is essential thrombocythemia patients. What happens is that this genus kinase receptor, this combines with the homodimeric type 1 cytokine receptor, which is present in erythropoietic precursor or the growth factors. So when this JAK2 protein combines with this homodimeric receptors, there is formation of erythropoietic cells or hematopoietic cells like RBCs, WBCs, and platelets. So when there is a mutation is this JAK2 gene, there is overproduction of JAK2 genus kinase protein. It combines with this homodimeric cytokine receptor on hematopoietic growth factors, and there is activation of JAK-STAT pathway, and there is increased proliferation of cells leading to the formation of thrombocytosis. Then in calreticulin, it is exclusive of both JAK2 and MPL mutation. Exact mechanism is not known, and it is seen in 25% of the essential thrombocythemia patients. Then MPL mutation, it is seen just in 5% of the patients. And there is a constitutive activation of thrombopoietin receptor protein, which gives rise to the excess formation of platelets. So now we'll talk about the mechanisms, like why both thrombosis and hemorrhage occurs in these patients. So what happens in these patients? Due to the excessive high number of platelets, there is clumping of platelets and there is clogging of the microcirculation, and there may be the formation of thrombus. But bleeding occurs because there may be acquired von Willebrand factor deficiency that can occur. What happens is this von Willebrand factors, this undergoes adsorption and proteolysis on the excess of platelets, and these multimers of von Willebrand factors, they decrease in the availability and there is decreased clot formation. So there is a kind of consumption coagulopathy which can lead to the superficial bleedings like mucosal bleeding or skin bleeding. Then in cases of extreme thrombocytosis, again, when the platelet is more than 15 lakh per liter, the platelet clumping and microvasculature occurs. There is a consumption of clotting factor and there is fibrinolysis, and which again can give rise to the bleeding in the form of GI bleed or after the bleeding after post-op in the post-op period. Then another mechanism by which bleeding occurs in these patients is the platelets that are being formed are dysfunctional. They are not having the proper they do not they release the abnormal granules, and glycoproteins are malformed, so they cannot form the clot. Then there can be liver dysfunction associated with these diseases, which can give rise to the deficiency of clotting factors. The drugs like aspirin and anticoagulation that may be given to these patients may be another cause of bleeding in these patients. So in patients having hemorrhagic tendency, they have easy bruising. The site of bleeding may be skin, eyes, gums, or urinary tract, or even in brain, which can give rise to stroke. Then there can be GI tract bleeding, which is generally the primary site of bleeding and complications. And bleeding is generally associated when the platelet count is more than 10 lakh per liter. In thrombotic tendency, the symptoms that we see are erythromelalgia that we've just seen the picture of. Ocular migraine, patient can present with TIA. There can be occlusion of coronary arteries giving rise to angina or MI. There can be the presentation can be in the form of DVT, or there can be pulmonary embolism, or there can be PAH associated with this. So what are the risk factors which are associated with increased thrombotic risk? JAK-STAT mutation, past history of thrombosis, WBC count more than 11,000 per microliter, obesity, male gender, and cardiovascular risk factors such as hypertension, diabetes, smoking, hypercholesterolemia, tobacco use, etc. And the patient who have higher risk of bleeding is if the platelet count is high, it is more than 10 lakh per microliter. The patient on drugs like aspirin or anticoagulants, the patient who have undergone the surgery also. So they are at the higher risk of hemorrhage. As we've already talked that this essential thrombocytosis is associated with complications in pregnancy. It can present as spontaneous abortions in almost 43% of the cases. There can be premature delivery, or there can be IUGR, intrauterine growth retardation associated with pregnancy. Physical examination depends upon what kind of a disease you have. If there is primary thrombocytosis, there can be lymphadenopathy, hepatosplenomegaly. There can be features of vasculitis. If it is secondary thrombocytosis, there can be presentation according to the underlying disease. Like if we think in terms of infection, there can be fever, there can be tachycardia, there can be, if it is a chronic infection, weight loss associated with it, and localizing signs of the particular infection. Suppose URTI, you can have cough, sputum production, chest pain, etc. If it is due to some autoimmune disorders like rheumatoid arthritis, celiac disease, IBD, etc., you'll have the symptoms associated with that, like joint involvement can be there. There can be bloody diarrhea, pain abdomen, etc. So in secondary thrombocytosis, it depends upon the cause of the thrombocytosis. How do we proceed for the investigations? We'll do some basic investigations such as complete blood count, markers of inflammation such as ESR, CRP. Then we'll do the peripheral smear. We'll do the coagulation profile, electrolytes, platelet aggregation studies if there are mutations. Then we'll go for the one of the most important tests if we are suspecting primary thrombocytosis is bone marrow biopsy. And of course, the last is genetic studies for the mutations. So this is the flow chart. How are we going to proceed for the investigation? You get a patient, you go for the blood count, and the platelet count is more than 4.5 lakh per microliter. You go for the peripheral smear, acute phase reactants, and iron studies. If the acute phase reactants are high, there may be a secondary cause. It may be a reactive thrombocytosis. So we locate for the secondary cause, we investigate for the secondary cause, and once that is been treated, we go for the repeat counts, and most probably there will be a resolution of this platelet count with the resolution of the underlying cause. In spurious thrombocytosis, we have there is no underlying cause. We have to rule it out by manual platelet count. Then with the if there is iron deficiency that is coming in the investigations, uh, we give the oral or injectable iron and look for the resolution. In most of the cases, again, this is a secondary cause, reactive thrombocytosis, it resolves. Now, when we do the repeat platelet count, if the blood count, if the thrombocytosis is persisting, then we think in terms of primary thrombocytosis. So we go for the evaluation of clonal thrombocytosis. We go for the bone marrow biopsy. We go for the genetic markers. If JAK2 is positive, along with raised erythropoietin level, most likely it is polycythemia vera. If BCR-ABL is positive, it goes in the favor of CML. Or if JAK2 is positive but erythropoietin levels are not raised, it goes in the favor of primary myelofibrosis. So this is just a slide. If we look at the third picture, so it shows the hyperlobulated abnormal platelet seen in essential thrombocytosis. So what are the bone marrow biopsy findings which suggest that it may not be essential thrombocytosis, but some myeloproliferative neoplasm, which is giving rise to the thrombocytosis. So the atypical megakaryocytes, increase in the number of myeloblasts, features suggestive of myelodysplastic syndrome, or reticulin fibrosis or collagen fibrosis on bone marrow are suggestive of hematological malignancy. What are the differential diagnoses of this thrombocytosis? Primary essential thrombocytosis are chronic myeloid leukemia, polycythemia vera, primary myelofibrosis, and secondary thrombocytosis, as we've already discussed. So, what are the management goals for these patients? Basically, the survival main aim of the treatment of the disease is to mitigate the symptoms, because there is no curative treatment that is available to us. So the management goals are mainly to elevate the symptoms and to prevent the complications in the form of hemorrhage or thrombosis, and treatment to prevent into transformation into the malignancy in the form of myelofibrosis or AML. So, when we think of treating the patients, we divide the patients into the following groups. Very low risk disease, low risk disease, intermediate risk disease, and high risk disease. So, a very low risk disease are the patients who have no history of thrombosis in the past, age is less than 60 years. But if JAK2 mutation is not present and there are no cardiovascular risk factors, then the patient is very low risk disease, and generally we need to just observe and follow up the patient. But if there are cardiovascular risk factors, we need to start the patient on anti-platelet drug as low dose aspirin, that is 80 to 100 milligram per day. In case of low risk disease, in which although there is no history of thrombosis present, age is less than 60 years, and JAK2 mutation is present, if there is no cardiovascular risk factor present, we can give OD dosing of aspirin. But if cardiovascular risk factors are present, low dose aspirin is to given twice daily. In intermediate risk, in which JAK2 mutation is positive and age is more than 60 years, and cardiovascular risk factors are absent, we continue the patient on twice daily aspirin. But if cardiovascular risk factors are present, we have to add the cytoreductive therapy in the form of hydroxyurea. Now, in the patient who come into the high risk category, in which there is a history of thrombosis, the previous episodes are there, and age is more than 60 years, with JAK-STAT mutation is there. If there's a history of arterial thrombosis, we give hydroxyurea with BD aspirin. But if there is a venous thrombosis, patient has to be put on cytoreductive therapy along with the anticoagulation. We have to see whether the thrombosis was provoked or unprovoked. If it is unprovoked, the anticoagulation has to continue lifelong. If it is provoked, then at least up to 6 months it is to be given. So again, the risk stratification slide. So what are the treatment modalities that we have for these patients? Generally, we have antiplatelet agent and cytoreductive therapy. So antiplatelet agent is low dose aspirin. Cytoreductive therapy includes hydroxyurea, anagrelide, and interferons. Then platelet pheresis is another modality used in emergency situations. And other drugs that are available are pipobroman, 32P, and busulfan. These are mainly used in the patients who have thrombocytosis with polycythemia vera. So let's talk about the low dose aspirin. Low dose aspirin, it prevents the thrombotic events and it controls the vasomotor symptoms, especially in the microcirculation. And it acts by inhibiting the thromboxane synthesis through COX-1 inhibitors irreversibly. The dose is 80 to 100 milligram once daily. Then, as we've already talked about, twice daily regimens can be used. It is avoided in the patient who are at the risk of bleeding, like if they have reduced level of 1 Willebrand factors or platelet count is more than 10 lakh per millimeter cube. So how do we decide we have to give aspirin or cytoreductive therapy along with or not? So in polycythemia vera, again, if the patient is low risk, age is less than 60 years and there's no thrombosis, we give aspirin plain. But if there has been a history of thrombosis or age is more than 60 years, aspirin plus cytoreductive therapy is to be given. In essential thrombocytosis, we have already talked about it. So let's talk about hydroxyurea in essential thrombocytosis. The preferred hydroxyurea is a preferred cytoreductive agent. It basically arrests the S phase of division and it reduces the platelet count. It decreases risk of thrombosis and thrombocytosis. Dose is 15 milligram per kg per day. The platelet count that we target is less than 4 lakh per millimeter cube. But the side effects it can cause is anemia and neutropenia. And important thing is it cannot be used in pregnancy because it is a teratogen. And it has an inherent tendency of transformation of thrombocytosis, essential thrombocytosis into AML in almost 5% of the patients. The side effects includes neutropenia, anemia, nausea, vomiting, hyperpigmentation, rash, oral ulcers, lichen planus-like lesions, and bone marrow suppression. Next is pegylated interferon. It is basically a cytokine which helps in decreasing the JAK2 allele burden and hence decreasing the platelet count. It reduces the thrombotic complication and reduces the abnormal clone in the patients. The dose is 45 microgram per week given subcutaneously, and it has anti-angiogenic, anti-proliferative, anti-apoptotic properties. And although it has no overall survival benefit and it does not reduce the transformation of ET into AML, generally, considering its high toxicity profile and subcutaneous route of administration, it is generally restricted for the patients less than 40 years of age or during pregnancy where it can be given and other drugs are teratogenic, or the patient who are intolerant or resistant to hydroxyurea. Another agent that we use in the treatment of essential thrombocytosis is anagrelide. It is a megakaryocyte maturation inhibitor and it reduces platelet production. Like hydroxyurea, it is not myelosuppressive. It does not suppress the bone marrow and does not produce the neutropenia or anemia. It is indicated in the patients who are intolerant to hydroxyurea or who have a hydroxyurea failure. It is a second line therapy and it is preferred in younger patients. The dose is 0.5 milligram BD and it can be titrated up to maximum of 2.5 milligram twice a day. This side effects include fluid retention, cardiac side effects such as tachycardia, palpitations, heart failure. There can be headaches associated with it. We have, for monitoring, we have to check the platelet count weekly and then monthly. And we have to do the cardiac baseline evaluation in the form of echo and ECG. It should not be given in the patients who have impaired hepatic function and not given in pregnancy. Then we come to platelet pheresis. Basically, it is a treatment reserved for the acute emergency conditions, such as when a patient comes with thrombosis or the patient who are having more than 10 lakh of per millimeter cube of platelet count. It is done by removing the platelets using the apheresis technique. And it is employed in patients with extreme degree of thrombocytosis, like 10 lakh per mm cube. It is a transient measure. It does not treat the disease. It helps in reducing the platelet count temporarily. And indication, as we've already talked, severe life-threatening organ dysfunction or acute bleeding due to acquired von Willebrand factor disease. There are other novel therapies that are in the evolution. One is ruxolitinib, which is a JAK1, JAK2 inhibitor. Indications are essential thrombocythemia, which is refractory to hydroxyurea. It has not yet got the US FDA approval. It can be used off-label. It reduces the constitutional symptoms associated with it, such as fatigue and pruritus. Dosing is 10 mg twice a day, and side effects include anemia, thrombocytopenia, and infection risk. Then this rusfertide, it is generally used in patients with polycythemia vera. Basically, it binds to the ferroportin protein, which is involved in uh, release of iron in the blood. So when this drug binds with ferroportin protein, it reduces the serum iron. So reduction in serum iron in turn reduces the iron-dependent erythropoiesis or thrombopoiesis. Indications are a phlebotomy-dependent patient who are undergoing phlebotomy more than 3 times in a year, or who are not responding to phlebotomy, or patient who are having symptomatic progressive splenomegaly. The hematocrit is not responding to the phlebotomy. In these patients, we can give this rusfertide. It is given by subcutaneous injection, and it may reduce thrombotic risk by lowering the iron-driven proliferation of thrombocytes. It is still in the phase 3 trials. Then givinostat, it is a histone deacetylase inhibitor. It downregulates JAK2 expression in the mutated cells. So it has a potential of reducing the platelet count as well as inflammation. Dosing is 50 to 100 milligram BD. Side effects are diarrhea and thrombocytopenia and cardiac side effect of Q2 prolongation. It is still in the phase 2 trials. Other pharmacological agents which are used in polycythemia vera with thrombocytosis are pipobroman 32P and busulfan. These are the all alkylating agents which are used in the treatment. So when we are using these cytoreductive agents, they have a lot of side effects. So we have to take care, we have to look for some special consideration, and which includes, while choosing a cytoreductive agents, the age, the comorbidities of the patient, whether the patient wants to go for a childbearing, or what is the anticipated life expectancy of the patient, that should be kept in mind. The patient who are receiving more than one cytotoxic agents, they have a higher risk of developing the myeloproliferative neoplasms such as MDS or AML. So we should try to add one non-leukomogenic drug such as interferons or anagrelide in these patients. In the patient who are resistant to hydroxyurea or intolerant cases, we prefer pegylated interferon 2A. And in pregnancy, we have to be very careful. In pregnancy, if we can just observe the patient and treat with aspirin, that is the best. But in case of high-risk patient, if cytoreductive therapy is to be added, then we have interferon is the safest therapy we have available. Aspirin and heparin are being used in case of increased risk of thrombosis in these patients. So we have been talking about hemorrhagic and thrombotic complications. So these occur in the patients who have extreme thrombocytosis. What is this extreme thrombocytosis? When the platelet count is more than 10 lakh per millimeter cube, it is defined as extreme thrombocytosis. It is not itself an indication of cytoreductive therapy, but if it may induce hemorrhage or thrombosis or adsorption of large amount of von Willebrand factor multimers, giving rise to the hemorrhage. So there we have to intervene. So if we have a patient with extreme thrombocytosis, he should be screened for acquired von Willebrand disease by seeing the ristocetin cofactor activity. So if the activity is reduced in these patients, if it is less than 30%, that means these patients have acquired von Willebrand factor disease. So in these patients, aspirin should not be used because it will increase the chances of bleeding in these patients. Cytoreductive therapy can be given in such cases in order to reduce the count of the platelet. In the follow-up, we check for the spleen size. We go for the CBC of the patient and the coagulation profile and hemostatic parameters. And we repeat the bone marrow biopsy if counts deteriorate or they're not responding as we have expected. So the prognosis of these patients is fairly good. Generally, they have the normal life expectancy, but a retrospective study has revealed that the 5-year survival rate of these patients is 81% and 10-year survival rate is approximately 64%. Then there is a variable rates of transformation to malignancies such as AML or MDS. And they may undergo into delayed disease progression into a fibrotic state called post-essential thrombocytosis myelofibrosis. So thank you for the patient listening. That's all.
Thank you so much, Dr. Prinsip, for an exhaustive talk on the thrombocytosis evaluation and management. It's a very day-to-day when everybody's seeing the CBCs, and then you just stop sharing.
Sir, I'm 1 sec. Yes.
No, you have to stop sharing.
Oh. Now is it okay?
No. So, okay.
Yeah.
So thank you very much. And I think everybody is agree with me that nowadays when we are seeing the CBC platelet is like 5 lakh, 6 lakh, then we used to say, okay, no problem. It is only in that condition if there is an infection is present. Otherwise, we have to evaluate because like we know that it's as an inflammatory marker also works the thrombocytosis. So thank you. I think any questions in the chat box or anybody want to ask? There is a one question, Neha. Can combination therapy provide superior outcomes than monotherapy in high risk essential thrombocytosis patients?
Sir, it depends if the patient is, yes, definitely in the terms like the transformation to AML and myelofibrosis is lesser in combination therapy as compared to the monotherapy, especially with hydroxyurea.
Anybody want to ask you any more questions? So this is our second last class of this ICP hematology course, and will be finished on 1st of July, and that day is a doctor's day also. So our last talk will be on the current ITP practice guidelines by Dr. Sekhar Chakravarti. Requesting to all the residents to just be prepared for your examinations, because after that class we will have an examination. 50 questions will be there, and you have to pass out that by 50% of that examination, then only you will get the certificates. So be ready for that. And at the outset, on behalf of the Dean ICP, Dr. Kamlesh Tiwari, and course director, Dr. Sudhir Mehta, I again thank you so much for giving your valuable time for the residents. So now we can wind up the session. Thank you, Dr. Prinsip, and thank you all
Thank
the
you, sir.
residents.
Thank you. Okay.